This documentary is educational, not medical advice. Talk to a qualified healthcare provider before making any decision about hormone therapy. Individual situations vary. On the morning of July 9, 2002, in a conference room at the National Press Club in Washington, D.C., a physician named Jacques Rassou stepped to a microphone. He was a principal investigator for a study called the Women's Health Initiative, the largest, most expensive study of women's health in American history. $625 million, more than 160,000 participants, 11 years of work. And he was about to deliver a verdict that would change medicine for the next 24 years. He told the room that hormone replacement therapy, the treatment that millions of American women were taking at that moment to manage the symptoms of menopause, carried an increased risk of breast cancer, cardiovascular disease, and stroke. The study had been stopped early. There was no peer review before the announcement. The full paper would not be published for another 8 days, but the news was out and it was heard. By the end of that day, the story was on every network. The New York Times put it on the front page, the Washington Post put it on the front page. Within a week, women across the country were calling their doctors, emptying their medicine cabinets, walking away from a treatment many had relied on for years. The number that did the damage was this one: 26%. A 26% increased risk of breast cancer. Here's what that number actually meant. Out of 10,000 women taking the specific drug tested in the study for 1 year, 8 more would develop breast cancer than would have otherwise. 8 per 10,000 per year. That's not 26% of women. That's 26% above a baseline risk that was already small.
For women in their 50s, the women most likely to be prescribed hormone therapy, the actual increase was even smaller, about 6 additional cases per 10,000 women per year. This is the difference between relative risk and absolute risk. On that morning, with that number, it triggered a nationwide panic that took 2 decades to correct. Within 3 months, hormone therapy prescriptions had dropped by nearly a third. Within 18 months, they had fallen 47%. By 2008, prescriptions were down nearly 70% from their peak. And for the next 2 decades, any woman who asked her doctor about hormone therapy was told some version of the same thing. The Women's Health Initiative showed it's dangerous. I can't help you. To understand what went wrong on July 9, 2002, you have to look at how the study was actually built. The WHI was launched in 1991, the brainchild of Dr. Bernadine Healy, the first woman to direct the National Institutes of Health. Her mission was real. Women had been systematically excluded from large clinical trials for generations. The WHI was her flagship response, designed to test, among other things, whether hormone therapy could prevent heart disease in postmenopausal women. But here is the detail that was not at the center of the July 9th announcement. The average age of a WHI participant at enrollment was 63 years old. Only about 30% of the women in the hormone trial were between 50 and 59. Most were in their late 60s and 70s. Many were more than a decade past their final menstrual period. These are not, for the most part, the women who are prescribed hormone therapy today. Hormone therapy today is most often prescribed to women in their late 40s and early 50s, going through menopause right now, with symptoms actively affecting their quality of life: hot flashes, night sweats, insomnia, cognitive changes, pain.
The WHI was not designed to test symptom relief. It was designed to test disease prevention in older women who had already been postmenopausal, on average, for more than 10 years. These are 2 very different medical questions, and the study answered only one of them. There is a second important detail. The hormone combination tested in the WHI was a specific one called PremPro. It contained 2 synthetic components: conjugated equine estrogens, derived from the urine of pregnant mares, and a synthetic progestin called medroxyprogesterone acetate. That is not the hormone combination most menopause specialists prescribe today. Today's standard of care more often uses transdermal estradiol, a bioidentical hormone applied through the skin, combined with micronized progesterone, which is molecularly identical to the progesterone the body produces. One drug, a population that didn't match how the drug was actually prescribed, a question that was different from the question most women and their doctors were actually asking. And then, on July 9, 2002, a Data Safety and Monitoring Board reviewed the interim numbers and the trial was halted. Instead of releasing the data through normal peer-reviewed channels, the NIH held a press conference. The subtlety, the age, the specific drug, relative versus absolute risk, was mostly stripped out for television. Dr. Joanne Manson was part of the WHI team. She saw the data from the inside. By 2013, she was leading a reanalysis that would change how the study was understood.
In a paper published in the Journal of the American Medical Association that year, Manson and her co-investigators broke the data down by age. What they found was that the broad warning masked a more complicated picture. For women in the 50 to 59 age group, several key risks look different. In the estrogen-only arm, coronary heart disease rates were lower than in the placebo group. This became known as the timing hypothesis, the idea that when hormone therapy is started close to menopause in appropriate candidates, the risk-benefit calculation may look substantially different from what the 2002 announcement implied. Years later, in the New England Journal of Medicine, Dr. Manson and Dr. Andrew Kaunitz wrote that the pendulum had swung too far. Before the WHI, HRT had been overused for disease prevention, and after it, underused, even for women who had clear indications for symptom management. She was not alone. In 2018, an oncologist named Abram Blooming and a psychologist named Carol Tavris published a book called Estrogen Matters. Blooming had spent his career treating women with cancer. He had watched his patients hit menopause and find that their primary care doctors would not consider hormone therapy because of the WHI. His book compiles a range of evidence: the French E3N cohort following around 80,000 women, the KEEPS trial, the age-stratified reanalyses of the WHI itself. The pattern across those studies pointed toward a different conclusion than the 2002 headline. The French data, in particular, suggested that bioidentical formulations may carry a different risk profile than synthetic combinations like Prempro. Dr. Wolf Utian, a former executive director of the North American Menopause Society, had been arguing for years that the original announcement overstated the practical risks for the women most likely to use hormone therapy. He called the doomsday framing of the 2002 announcement, quote, a lot over the top. By the 2020s, a younger generation of doctors was taking the same argument public: Mary Claire Haver, Louise Newson, Rachel Rubin, and others. On social media, on podcasts, in best-selling books. What they told their audiences was the same thing. The story you were told in 2002 was incomplete. There are appropriate candidates for hormone therapy who are not being offered it. Your symptoms are real.
There are evidence-based options, but they were pushing against a 20-year institutional consensus. Medical school curricula had taught the WHI as a cautionary tale. Most primary care physicians had been trained through the 2000s and 2010s to treat hormone therapy with extreme caution. That is what many, many women were told for more than 2 decades. On November 10, 2025, the U.S. Food and Drug Administration announced something it rarely does: a substantive revision of how it labels a long-approved class of drugs. The agency stated that the black box warning, the FDA's most prominent safety warning, would be removed from menopausal hormone therapy products. The changes, set to take effect in February 2026, addressed the warnings related to breast cancer, cardiovascular disease, and probable dementia. The FDA also updated the labeling to reflect current evidence regarding the timing of HRT initiation. The new labeling acknowledges benefits that had been buried in the public conversation for more than 2 decades. For women who start hormone therapy within roughly 10 years of menopause and before age 60, published research suggests meaningful reductions in risk of cardiovascular disease, fractures, and possibly Alzheimer's disease. These are not universal guarantees. The magnitude depends on timing, individual health history, and how long therapy is continued. But the pattern, that appropriately timed hormone therapy in appropriate candidates can carry substantial benefits, is now reflected in FDA labeling rather than obscured by it. The FDA reversal does not undo 24 years of cautious prescribing. It doesn't bring back the bone density women lost during years they might have been on therapy. It doesn't bring back the sleep, the cognitive clarity, the professional performance many women lost, often without knowing there was an evidence-based option that might have helped. And even now, hormone therapy prescribing has moved only modestly.
As Dr. Manson has noted in interviews since the reversal, it will take years to rebuild what was lost. So if you are a woman in your 40s or 50s, if you are awake at 2 a.m. drenched in sweat, if your joints hurt, if your brain feels like it's running on low battery, if you have been told there's nothing to do, there are potentially things to do. You can ask your provider about the different formulations of hormone therapy, including transdermal options and bioidentical formulations. You can ask about the timing hypothesis. You can ask about your personal history and how it factors into the decision. And if your current doctor hasn't been trained specifically in menopause care, you can find a certified menopause specialist through the Menopause Society. My name is Sarah Mitchell. I wrote a book called Perimenopause Reset that goes through this history in more depth, with additional research and practical steps. The link is in the description. If this documentary was useful, subscribe to the channel. The next episode is about medical gaslighting, why so many women in perimenopause are told their symptoms aren't real, and what to do about it. July 9, 2002, changed how medicine was talking about hormone therapy. November 10, 2025, brought the conversation back to something closer to what the research supports. It's time for the rest of us to catch up.